الأعزاء cardiac CT scan. Overview. We will discuss A. The different cardiac axes, the cardiac anatomy in the order of normal blood flow from the right to left, coronary arteries anatomy and anomalies. Cardiac axes include 4 chamber view, 3 chamber view, 5 and 2 chamber view. Cardiac anatomy from right to left include right atrium, Crista terminalis, coronary sinus, right atrial appendage, right ventricle, pulmonary valve, pulmonary veins, left atrial appendage, left ventricle, and then aortic valve. Cardiac CT with ECG triggering offers good image quality of the heart when compared to CT performed for other purposes. As in any other field of radiology, analysis of the acquired images require a systematic approach. First of all, it is important to understand that the orientation of the heart in the human body differs from that of other anatomic structures. The right ventricle, for example, doesn't lie completely on the right, but more anterior. Left ventricle doesn't lie on the left, but more posterior. Also, the heart doesn't always maintain the same position within the mediastinum. In young people, it tends to have a vertical orientation, whereas in older people, it tends to rest on the diaphragm, more horizontal orientation. Cardiologists analyze the heart using cardiac axes. These axes are also used in cardiac CT and MRI. It must be reconstructed in order to assess the heart properly. Axial slices, such as those imaged on the next slide, are useful for a global assessment of the morphology of the heart and its relation to the pericardium. This is the axial slices through the heart. Short axis, aortic valve, left atrium, RVOT, and this is the right atrial appendage. We will discuss in other reviews, in other slides. For chamber review, on the left is a 4-chamber view achieved by rotating upwards from the apex of the heart on axial slices. يعني هو ما يطلع هالشكل بالاكسيال سلايد، نسوي rotation upward نحصل على 4-chamber view. In this axis, the right ventricle is projected next to the right atrium. This is the right ventricle, right atrium, and the left ventricle next to left atrium. Mitral valve comes into view and depends on the contrast protocol. Tricuspid valve may also be visible. Another feature of this cardiac axis is that of the apex of the heart is well demarcated. Note that the apex is formed by the left ventricle. 3-chamber view, when the border between the mitral and aortic valve is localized on the axial slices and the images are rotated from this point, 3-chamber view like the image on the left can be reconstructed. On this image, the left atrium, left ventricle, mitral valve, aortic valve, and the proximal aorta ascents are visible, أو ascending aorta يعني. 5-chamber view. On the left is an image of 5-chamber view, which is similar to 4-chamber view, but additionally displays the aortic valve and left ventricle outflow. Left ventricle outflow, now more clear. This view is achieved by rotating the 4-chamber view a little more cranially. هاي يمكن على الجهاز يعني أكثر نفهمها. Two-chamber view. The two-chamber view in the image on the left is achieved by rotating the images perpendicularly to mitral valve and parallel to cardiac septum, perpendicular to mitral and parallel to septum. This axis gives an overview of the left atrium and ventricle in mitral valve. This is a good view for analyze ventricular function, especially that of the inferior and anterior walls. هذا inferior and this is anterior wall. For attaining functional data, consecutive short axes must be reconstructed making use of the 3 and 4 chamber view. يعني from 4 chamber and 3 chamber we can get short axis view through the left ventricle to assess its function. Cardiac anatomy from right to left. The cardiac anatomy will be discussed in the order of normal blood flow from right to left. We will start with right atrium. In the normal situation, contrast will be injected intravenously, usually in the arm, reaching the right atrium via superior vena cava. The right atrium has an anterolateral position in the heart and lies inferior to the left atrium. يعني هو anterior and inferior. The superior vena cava enters through the roof of the right atrium, يعني from above, from the roof of the right atrium. The inferior vena cava enters the right atrium below and near the cardiac septum. Another structure that carries the blood towards the right atrium is the coronary sinus, venous return of the coronaries, which enters anterior to and just to the left of the inferior vena cava. تقريبا هنا الcoronary sinus. This is the coronary sinus and this is the IVC. Axial left, coronal oblique on the right side, the right picture, reconstruction of the heart depicting the right atrium and its main contributory blood vessels, coronary sinus, blue arrow, and superior and inferior vena cava. Crista terminalis. In the right atrium lies the crista terminalis, a muscular ridge that runs from the entrance of the superior vena cava to that of inferior vena cava. This structure separates the smooth part of the right atrium, the sinus venosus, from the trabeculated right atrial appendage. On the images on the left, it is visible as a smooth linear structure. This is smooth linear structure. This is not always the case. However, it may simulate a mass. اوكي ممكن نسال الزملاء اذا يحبون يكتبون بالتعليقات بعد اذن الاساتذه انه شنو اسمها muscles of right atrial appendage. احنا قلنا trabeculize فشنو نسميها muscles of right atrial appendage. The coronary sinus is the main draining vein of the myocardium. It runs in the atrioventricular groove on the posterior surface of the heart and enters the right atrium in the vicinity of tricuspid valve. On the left is a reconstruction illustrating the course run by the coronary sinus in the atrioventricular groove on the posterior surface of the heart. This is right atrial appendage. The right atrial appendage is the trabeculized part of the right atrium. It partially covers the atrioventricular groove and the right coronary artery runs in it. right coronary artery runs in the atrioventricular groove. Characteristically, it is flat, triangular in shape, contains small muscular bundles which run parallel to the atrium itself. Axial left picture and the 3D reconstructions on the right of the heart demonstrating the right atrial appendage. Blue arrow. This is the right atrial appendage. Right ventricle. Blood leaves the right atrium and enters the right ventricle via the tricuspid valve. This valve has 3 leaflets and 3 papillary muscles, which partially inserted on the septum. In contrast to the papillary muscles of the mitral valve, which do not. يعني احنا we have 3 papillary muscles, anterior, posterior, and septal papillary muscle, septal leaflet, tricuspid valve with septal leaflet, anterior and posterior leaflet. Of mitral valve, we have no septal papillary, just have anterolateral and posteromedial papillary muscles. The right ventricle is shaped differently to the left ventricle. The left ventricle is cylindrical in shape, and the cavity of the right ventricle is effectively wrapped around it. The right ventricle also has a thinner wall, which is more trabeculated, especially towards the apex. Moderator band is another distinguishing feature of right ventricle. It runs from the septum to the lateral wall. The moderator band plays a key role in electrophysiological conduction of the right ventricle's free wall. Pulmonary valve. Next, blood runs towards the pulmonary valve. First enters the smooth muscular infundibulum of the right ventricle. Pulmonary valve has 3 cusps and is separated from the tricuspid valve by a thick muscle known as Crista.
صوت انقطع.
Cusps and is separated from the tricuspid valve by a thick muscle known as Crista supraventricularis أو أحيانا نسميها conus. Blue arrow in the image. This differs from left ventricle outflow tract, where mitral and aortic valve lies side by side. Reconstruction showing the tricuspid and pulmonary valve, as well as cavity of the right ventricle. The blue arrow is indicated the Crista supraventricularis. Characteristic right ventricle. How we differ the right ventricle from left ventricle. Not always the right ventricle lie anteriorly and to the right, as in congenital heart disease. In some congenital heart disease, we should know the characteristic feature of right ventricle. It has a moderator band, septal papillary muscle, infundibulum, fibrous continuity, aortic valve outflow has no fibrous continuity, and triangular in shape, more trabeculated, with apically displaced tricuspid valve. يعني الترايكاسبيد valve يكون more near to apex, not like يعني higher than mitral valve. Pulmonary veins. Oxygen-rich blood enters the left atrium via the pulmonary veins. In most cases, there are 2 pulmonary veins on the left and 2 on the right. The middle pulmonary veins usually drain into the superior pulmonary vein. Axial reconstruction showing the pulmonary veins as they enter the left atrium. There are frequent variations in pulmonary vein anatomy, however, especially on the right, where an anomalous insertion is associated with atrial fibrillation. Left atrial appendage. The left atrial appendage is a finger-like trabeculated structure which originates supralaterally in the left atrium. It lies over the left atrioventricular groove and partially covers the left coronary artery. It is a small, parallel running muscle, should not be mistaken for a thrombus. يعني left atrial appendage يكون more trabeculated than right atrial appendage, and we should not mistaken as a thrombus. When assessing the coronary arteries, the left atrial appendage must be removed. On that, left circumflex and the proximal LAD may be visualized. This is appendage, and here we remove it to assess proximal LAD and circumflex artery. Left ventricle. Blood enters the left ventricle via the mitral valve. This is a complex valve consisting of an annulus, posterior and anterior leaflets. The leaflets are connected to the papillary muscles via cord-like tendons called chordae tendineae. Papillary muscles insert into the lateral and posterior walls, as well as the apex of the left ventricle. In normal situation, the left ventricle has a uniform thickness, varying in diastolically from 0.6 to 1 centimeter in male, from 0.6 to 0.9 centimeter in female. Blood enters the aortic valve via the left ventricular outflow tract. Note that there appears to be a fibrous connection between the mitral and aortic valve. يعني نسميه in fibrous continuity. No muscle between them. Left reconstruction, axial reconstruction, 3-chamber view, coronal reconstruction of the heart illustrated the relationship between the left atrium, ventricle, and aortic root. Here the short axis view, axial level, show the aortic valve in short axis, right, left, and non-coronary cusp. Here we have the left atrium, right ventricular outflow. This is the right coronary artery, and this is the left coronary artery. Aortic valve, like the pulmonary valve, the aortic valve has 3 cusps. Just cranially to it, there is a slight dilatation of the aortic root. This is the sinus of Valsalva. It fills with the blood during diastole, supplying the coronary arteries with oxygenated rich blood. The image on the right shows that the coronary arteries originate fairly cranially on the border of the ascending aorta. The cusp of the aortic valve are named according to their relationship with the coronary arteries, namely right coronary, left coronary, and non-coronary cusp. Coronary arteries, anatomy and anomalies, overview. Left coronary artery, left anterior descending, circumflex, right coronary artery, coronary anomalies, and we will discuss interarterial LCA, ALCAPA, myocardial bridging, and fistula. In this anterior projection, an overview of the coronary arteries. In the anterior left main or left coronary artery, divided into left anterior descending with its diagonal branches T1, T2, supply the lateral alveoli, and septal branches which perforate the septum, also called perforating branches, circumflex with its marginal branches. Right coronary artery, acute marginal branch, AV nodal branch, posterior descending artery in right dominance, if the right coronary is the dominance. Oblique projection on the left, an overview of the coronary arteries in the right anterior oblique projection. Left main or left coronary artery, oblique projection, we will see the left main or left coronary artery, left anterior descending, diagonal branches, septal branches, circumflex with its marginal branches. And we will see the right coronary artery with acute marginal, AV nodal, posterior descending artery. On the left, an overview of the coronary artery in the lateral projection. This is the left coronary artery, LAD, with its branches, left circumflex with its branches. Right coronary artery هيكون posteriorly. Left coronary artery is also known as the left main stem or left main coronary. Left coronary artery arises from the left coronary cusp. Aortic valve has 3 leaflets, each having a cusp or cup-like configuration. These are known as the left coronary cusp, right coronary and non-coronary cusp. Just above the aortic valve, there are anatomic dilatation of the ascending aorta, known as sinus of Valsalva. Left aortic sinus gives rise to the left coronary artery. Right coronary sinus or right aortic sinus, which lies anteriorly, gives rise to the right coronary artery. Non-coronary is positioned on the right side. Left coronary artery divides almost immediately into circumflex artery and left anterior descending artery. On the left, an axial CT image, left coronary artery travels between the right ventricular outflow, tracts anteriorly, and the left atrium posteriorly, and divides into LAD and circumflex. On the image of the left, we see the left main artery dividing into circumflex with obtuse marginal branch, LAD with diagonal branches. On volume rendered images, the left atrial appendage needs to be removed to get a good look for LCA. We mentioned before. In 15% of cases, a third branch arises in between the LAD and circumflex, known as the ramus intermedius or intermediate branch. This intermediate branch behaves as a diagonal branch of the left circumflex. Left anterior descending. Left anterior descending travels in the anterior interventricular groove and continues up to the apex of the heart. The LAD supplies the anterior part of the septum with septal branches, طبعا anterior 2/3 of septum, with septal branches, and anterior wall of the left ventricle with diagonal branches. anterior wall of left ventricle with diagonal branches. اليوم الصبح ذكرناه بالمحاضرة، كنا anterior and lateral wall. The LID, lateral wall by diagonal of circumflex, anterior wall by diagonal of LID. The LID supplies most of the left ventricle and also the AV bundle. احنا عندنا mnemonic equal diagonal branches arises from LID. يعني نفس الحرف حرف T. The diagonal branches come off the LID and runs laterally to supply the anterior lateral wall of the left ventricle. The first diagonal branch serves as the boundary between the proximal and mid portion of the LID. There can be one or more diagonal branches. Circumflex lies in the left AV groove, يعني atrioventricular groove. Between the left atrium and left ventricle and supply the vessels of the lateral wall of the left ventricle. These vessels are known as obtuse marginal, 1, 2, or more, because they supply the lateral margin of the left ventricle and the branch off with an obtuse angle. In most cases, the circumflex ends as an obtuse marginal branch, but 10% of patients have a left dominant circulation in which the circumflex also supplies the posterior descending artery. Marginal branches arise from circumflex and supply the lateral margin of the left ventricle. Right coronary artery. The right coronary artery arises from the anterior sinus of Valsalva, أو يعني نفس الاسم اللي هو right coronary sinus, and courses through the right atrioventricular groove between the right atrium and right ventricle to the left to the inferior part of the septum. In 50 to 60%, the first branch of the RCA is the small conus branch. First branch conus that supplies the right ventricular outflow tract. This is the conus branch. In 20 to 30%, the conus branch arises directly from the aorta. In 60%, sinus nodal artery arises as a second branch of RCA. عفوا مديت الشر هنا. This one that runs posteriorly to the SA node. In 40%, it originates from the circumflex. The next branches are some diagonals that run anteriorly to supply the anterior wall of the right ventricle. Large acute marginal branch comes off with an acute angle and runs along the margin of the right ventricle above the diaphragm. The RCA continues in the AV groove posteriorly and gives off a branch of the AV node, يعني atrioventricular node. هنا اللي هي تكون at inferior part of interarterial septum تقريبا. The RCA continues in the AV groove posteriorly, In 65% of cases, the posterior descending artery is a branch of RCA in right dominant circulation. The PDA supplies the inferior wall of the left ventricle and inferior part of the septum, يعني inferior 1/3. On the image on the far left here, we see the most common situation in which the RCA comes off the right cusp and will provide the conus branch at a lower level. Not clear here. On the image next to it, we see a conus branch that comes off directly from the aorta. More common arise from RCA, sometimes arise directly from the aorta. About 20 to 30% arise from aorta. The large acute marginal branch supplies the lateral wall of the right ventricle. In this case, there is a right dominant circulation because the posterior descending artery comes from RCA. Coronary anomalies are uncommon with a prevalence of 1%. Early detection and evaluation of coronary artery anomalies is essential because of their potential association with myocardial ischemia and sudden death. With the increased use of cardiac CT, we will see these anomalies more frequently. Coronary anomalies can be differentiated into anomalies of the origin, the course, and termination. In this table, anomalies of the origin include anomalous origin of coronary artery from pulmonary artery, single coronary artery, origin from non-coronary cusp, anomalies of the course, myocardial bridging, and duplication. Anomalies of termination include coronary artery fistula, etc. Cardiac termination. The illustration in the left upper corner is the most common and clinically significant anomaly. There is an anomalous origin of the LCA from the right sinus of Valsalva, and the LCA courses between the aorta and pulmonary. This interarterial course can lead to compression of the LCA, resulting in myocardial ischemia. The other anomalies in the figure on the left are not hemodynamically significant because it is not in between the great arteries and no compression on them. Interarterial left coronary artery. On the left image of a patient with an anomalous origin of the left coronary artery from the right sinus of Valsalva. And coursing between the aorta and pulmonary artery. Sudden death is frequently observed in these patients. ALCAPA. On the left image of a patient with an anomalous origin of the LCA from the pulmonary artery, also known as left coronary artery, PA, pulmonary artery. Anomalous left coronary artery from pulmonary artery results in the left ventricular myocardium being perfused by relatively desaturated blood under low pressure. مدام هو pulmonary artery في right side deoxygenated راح يكون desaturation pressure on right side أقل من pressure on left side, leading to myocardial ischemia. ALCAPA is a rare congenital cardiac anomaly accounting for approximately 0.2 to 0.5% of all congenital heart disease. Approximately 85% of patients present with the clinical symptoms of congestive heart failure within the first 1 to 2 months of life. This is pulmonary artery, and this is the left coronary artery. While the right coronary artery originate or arise from aorta. Myocardial bridging is most commonly observed of the LAD. The depth of the vessel under the myocardium is more important than the length of the myocardial bridging. يعني كل ما كان the thickness of muscle above the coronary artery راح يكون more significant, whether the distance short or long. There is debate whether some of these myocardial bridges are hemodynamically significant. So it is hemodynamically not significant usually, but in case of insertion of stent, this contraction of this muscle may lead to fracture or destruction of the stent. Fistula. On the image on the left, we see a large LAD giving rise to a large septal branch that terminate in the right ventricle. راح نشوف coronary يعني flow from coronary sinus to the RV cavity. This is the right, this is the large left coronary artery with septal branch. A large septal branch terminates in the right ventricle. And thank you.